Hello, I'm Miguel Peña, urologist here from Mexico. I'm here with Jochen Walz, and we're gonna discuss some topics. Hello, Dr. Walz. First question: what are the main considerations you take into account when planning to do bilateral, unilateral, or no nerve sparing in a patient with no palpable disease?
The daily practice questions indeed, and all the results we get nowadays with surgery depend very much on how you select and how you decide what to do and what not to do. What you would like to get is the compromise between oncology and the functional outcome, and we need to balance those. And there's always, like, you can gain more on oncology side but losing at the same time on the functional side, and the other way around. And the challenge is to find that compromise. I personally rely still on mammograms. They give me a baseline risk of what kind of extraprostatic extension I could get on a side or seminal vesical invasion. But that is obviously not the only way to decide, because nowadays we have MRI available. And the issue I have with MRI is that it is not yet standardized as a predictor to be integrated into statistical predictor models. The PSA, straightforward. A digital rectal exam might be subjective, but it's straightforward to be interpreted. The Gleason score is straightforward, even though there might be variability from pathologist to another one, but it's probably quite good reproducible and can be entered into decision making. But prediction of an extraprostatic extension, yes and no, usually is not really helpful. So you need to grade it 1 to 5 ideally, so you get some risk scales as you have with the Gleason score as well. And that is not standardized and difficult to integrate. It might work if it comes from one radiologist, will not work if it comes from another radiologist. That's why I do not use it right now inside of a statistical model, because the variable that I enter is not of good quality. But I consider it obviously when I decide then with information from the nomogram and the imaging, and then I can work around the location that I see on MRI and the risk that I would get from the predictive model. And if I would have, for example, a lesion visible on the base that is in contact with the pseudocapsule, I might take a little bit a bigger margin at that time point, safety margin at that time point. And then if I know I'm outside of the area of risk, then I would go closer to the prostate and do a better nerve sparing in that area. And the same applies for the anterior lesion, a lesion that might be at the bladder neck, where I might then work around it, have a little bit more safety margin at that level, not trying to get a bladder neck preservation. Same at the apex. So imaging really helps us to understand where the main tumor bulge is and where we should work around it, and where we can individualize the dissection to get the best compromise between oncology and functional outcome.
Thank you very much. Another question about staging. What are your thoughts about replacing the clinical staging with the newer molecular imaging staging?
PET PSMA,
for PET example.
PSMA. It is for sure more sensitive and performing better than what we had with conventional imaging, where we basically knew in all high-risk prostate, not all, but in many high-risk prostate cancer patients, that we have false negatives. So we don't see anything because the disease is just not detectable with this kind of imaging. And molecular imaging is able to define disease at a smaller volume level, but we are far from a situation where we can really blindly rely on it. The sensitivity, for example, to detect lymph node metastases is only at 40%. You will miss a lot of lymph node metastases if you blindly rely on these. And that makes it a tool that helps us to understand who might need intensified treatment if it is positive, because we know they will do worse on the long term. But it's nothing where we can say we don't need surgical staging anymore because we can upfront say if this patient does have lymph node metastasis, that's not working. So I still heavily rely on lymph node dissection. First, because I think it's the best staging procedure we have, and the results will influence the outcome of the patient. Are you doing adjuvant radiotherapy or not? Are you doing an adjuvant hormonal therapy or not? Or do you simply do a surveillance afterwards? So that's why it's very important. And there might be also a therapeutic aspect to it. And we will right now, probably in a few minutes, hear something about the effect of the lymph node dissection nowadays and the cancer control on the long term, which seems to improve metastasis-free survival.
Thank you very much. A different question of another very new topic, well, very changing topic. It's focal therapy. What do you think is the biggest setback for focal therapy, and where do we have to focus our research in order to get a significant advancement?
I think what currently is lacking for focal therapy is not necessarily the trials. We have some of them ongoing and they were done, but it's just like the fact that we do not really know what we actually are aiming for. We do not know what kind of oncological outcomes we would like to have. Is it absence of positive biopsy? Is it absence of PSA progression? Is it absence of clinical progression? We don't know. And as long as we do not have a standardized endpoint, we will not be able to conclude something of trials because we do not know what we should actually conclude as an endpoint. And that is a point. And then we do not really know how to get these endpoints. Do we need to have imaging? Do we need to have biopsy? Is it PSA? So there are a lot of questions right now, more questions right now than actually answers, and way more as what we had at the beginning when everybody was really enthusiastic about it because we thought we see the lesion right now, so we just treat it and that's it. And we would not need any radical whole gland treatment anymore. And there was a lot of enthusiasm around it in many places, and that really cooled down. And I'm not really sure that with this right now we are able to see clearer. And then we have also the problem with the indications. So we are running behind the indications. At the beginning it was an alternative for active surveillance. Patients understood no treatment means no treatment. That is not focal therapy, no ADT for 6 months, whatever, no treatment at all. So that is no more an option. Then they went for low volume, intermediate risk. These are going for active surveillance today now also. And then you're getting to a disease that indeed has more potential, but then probably just ablating the lesion where you're still unsure if you really ablate everything is enough. So for radiotherapy, we're adding ADT to it. And we know we need it in order to be more effective. For surgery, we're adding lymph node dissection to it because we know we would need it because there might be a risk, might be 20, 30% of having lymph node metastases. You don't have that for focal therapy. And that's once more, we don't know how actually we should treat those patients in the best way and what might be then the endpoint of a treatment we have done with focal therapy.
Thank you. And now a completely different question about what advice would you give residents to get the best training in their different centers?
So I'm working in southern France, in Marseille, and we are lucky that we are part of the EROS training centers, the European Robotic Urology section, and they have a standardized training for robotic surgery if that is, for example, something you are aiming for. And we're in a cancer center, so we're doing only oncology, and obviously surgery is a big part here. And we follow that standardized curriculum, make sure that the residents, the trainees get something that is renowned and where we have something repeatable as well. So we have a rotational system, the residents come in, the fellows come in, and we would like to make sure that they all get a benefit out of this training, that they do one step after another. And it's like with surgery. The more it's standardized, the more it's reproducible, the more you will end up with a success. And then you also need to measure. Like surgery, you would like to know if your results are good or not. Only if you measure, you can recognize if you're doing a good job or not. That's why you need to evaluate also the increase of knowledge and performance a resident actually gets to make sure that the program is actually helpful and that things go forward. And that's a give and take between the trainers and the trainees. We all need to have a benefit from each other, and there needs to be exchange. And you need to have this setting and get that ongoing.
Thank you very much.
You're welcome.